Welcome back, everyone! We've officially hit a massive double-digit milestone in our 15-part explainer series. Today, we're transitioning away from the male breast procedures we covered back in Part 9, and we're stepping right into the highly nuanced, kind of tricky world of breast-conserving surgery. If you've been following along, you already know just how incredibly detailed breast surgery coding can get, and let me tell you, this module is absolutely crucial for anyone looking to truly master the space.
Okay, let's dive into this. We're going to move fast through our logic tree today. We'll start with our welcome, define these specific surgeries, tackle Sentinel node mapping rules, sort out radiology versus surgeon billing, do a live operative case audit, and end with the final checklist.
All right, kicking things off with Section 1, welcome to Part 10.
And moving right along to Section 2, defining breast-conserving surgeries. Let's get into the clinical anatomy.
So our absolute main goal today is mastering that delicate balance between oncologic clearance and cosmetic preservation. And it really all comes down to a concept called oncologic intent. You see, a partial mastectomy, which is CPT code 19301, is a breast-conserving surgery specifically performed to remove a cancerous tumor along with a surrounding margin of normal, healthy tissue. We are strictly coding for cancer resections here, so we don't use this code for a simple benign cyst. The absolute keyword to hunt for in your documentation is margins. Oh, and a quick pro tip. If your patient has to return during the postoperative global period for a re-excision because they had positive or close margins, you still report 19301. You just have to make sure to append modifier 58 for a staged or related procedure.
Notice that dotted line right there, highlighting the removal of the entire lesion plus that surrounding healthy tissue margin? That intentional extra clearance is exactly what elevates this procedure from a standard simple excision into a partial mastectomy. And depending on your surgeon's specific training, you might actually see this documented as a lumpectomy, a tylectomy, a segmentectomy, or even a quadrantectomy. But don't let the vocabulary throw you off. From a coding perspective, all of those terms map right back to our partial mastectomy codes.
Now, what's really interesting about this slide is the critical fork in the road for coders. We've got code 19301 versus code 19302. And the entire difference literally rests on one single question. Did the surgeon perform a formal axillary node dissection? If they just removed the tumor with margins, it's 19301. But if they also performed an axillary lymphadenectomy, which, by the way, you might sometimes see coded standalone as 38740 for superficial or 38745 for complete, you actually bundle them together into the single code 19302.
But here's the catch with reporting 19302. Your surgeon cannot just pluck out a random lymph node. The rule here is incredibly strict. It requires a full, formal dissection of at least levels I and II of the axillary lymph nodes. As you can see anatomically, level 1 sits inferior to the lower edge of the pectoralis minor muscle, and level 2 sits completely deep to that muscle. If your surgeon just takes a few superficial nodes, or they only do a targeted biopsy, 19302 is completely off the table.
Which naturally brings us to Section 3, Sentinel node mapping rules. This is a massive, multi-code powerhouse. We're stepping into one of the most heavily audited areas in surgical coding. The sentinel lymph node is defined as the very first lymph node to which cancer cells are most likely to travel from a primary tumor. Think of it as the crucial first stop, or the primary security guard on duty. If this specific node is clear of cancer, the general clinical assumption is that the cancer hasn't spread any further down the lymphatic chain.
And this brilliantly illustrates exactly how surgeons find that microscopic gateway during a procedure. It's called intraoperative mapping. It involves injecting non-radioactive dyes, like isosulfan blue or indocyanine green, or even using radioactive tracers right into the breast. The surgeon then literally watches the lymphatic channels carry that dye to the axilla. They track it with their own eyes or a specialized probe to zero in on that exact first node.
When your surgeon performs this intraoperative dye injection and tracking, you report the add-on code 38900, but I am flashing a giant audit alert right here, guys, because this is an add-on code. 38900 can never, ever be billed alone. It must be strictly paired with a specific, approved parent code. If you try to bill this without a parent code, like 19301 for the lumpectomy, or maybe 38525 for a deep node excision, your claim is going to be instantly denied. Zero exceptions.
Okay, so once the surgeon maps and finds that sentinel node, they actually have to remove it. And this is where we break down the biopsy depth roles. Code 38500 is for open, superficial nodes. Code 38525 is for open, deep axillary nodes.
Now you might be wondering, how do you know which one to pick? You absolutely must look for depth documentation in the operative report. Are they working above or below the fascia? By anatomical definition, levels 2 and 3 are always deep. Level 1 nodes, however, can be either superficial or deep, so you've got to read those surgical notes incredibly carefully to accurately choose between 38500 and 38525.
Moving right into Section 4, Radiology versus Surgeon Billing. Let's shift our focus to a cross-specialty billing complication that actually happens before the patient even hits the operating table. We're talking about preoperative wire or clip localization devices. Very often, a patient with a tiny, non-palpable tumor goes to the radiology suite first. The radiologist places a clip to mark the tumor and they'll bill a code like 19285. Then, the surgeon just codes the 19301 for the excision. But if the surgeon places the device themselves in the holding area or the OR and then immediately performs the partial mastectomy, the surgeon bills for both. They just have to append a modifier 59 or XA to that localization placement code to prove it was a distinct, separate procedural service from the main excision.
Let's move on and see how this builds in the real world. Section 5, Live Operative Case Audit.
All right, it's time to put our detective hats on and solve a live case together. Here is a crucial excerpt from our operative report. We have a 52-year-old female patient. A preoperative ultrasound clip was already placed by radiology. Now, in the OR, our surgeon injects isosulfan blue dye for mapping. A lumpectomy is performed, removing a 2-centimeter tumor with negative margins. Through a separate incision, 2 blue-stained sentinel lymph nodes are identified deep in the right axilla and excised for frozen section.
Let's sequentially assemble our surgeon's codes for this case based on the exact rules we just learned. First, the lumpectomy with negative margins. Because it was just the tumor and the margins, no full axillary dissection, we assign 19301 for the partial mastectomy. Next up, we look at the nodes. The surgeon excised sentinel nodes deep in the axilla through a separate incision, right? So we assign 38525 for a deep open biopsy, and we add modifier 51 for a multiple procedure. Finally, the surgeon personally injected the blue dye for intraoperative mapping, giving us our add-on code 38900. And since everything happened on the right side, we just append the RT modifier to all of them. The radiologist, of course, would separately bill for that pre-op clip.
And that brings us to Section 6, Final Checklist and Wrap-Up. Beautifully done, everyone. That is exactly how you map out these complex, multi-code scenarios. When you're auditing breast-conserving surgeries, literally keep this checklist on your desk. First, always confirm oncologic intent. Look for the word margins to use 19301. Second, if you're ever tempted to use 19302, verify that a formal level 1 and 2 axillary dissection actually took place, not just a sentinel biopsy. Third, check the depth documentation, above or below the fascia, to confidently choose between your node excision codes. And finally, append the proper modifiers if your surgeon places their own localization devices. So the crucial point is this: the operative report documentation holds all the answers. You just have to know exactly which keywords trigger which code.
And that wraps up our deep dive into breast-conserving surgeries. But ask yourself, if the documentation is this strict just for saving tissue, how incredibly complex do the codes get when the surgeon has to remove everything? The surgical intensity is literally only going to scale up from here. Up next in Part 11, we are going to be tackling total and radical mastectomies, breaking down those massive resections coded under 19303 through 19307. Thank you for watching, keep coding with confidence, and make sure to subscribe to Decode Healthcare with Harshal. See you in Part 11.